Dr. Thornton is a prime example of all the above. He's graciously agreed to be our keynote and is absolutely deserving. Dr. Thornton's address will give you all the bits of details that he'd like to give you. What I'd like to give him as an introduction is my gratitude for all he's done for Cook patients and Cook research. Virtuous circles, as circles, don't have a beginning. There is no start to a circle. But virtuous flywheels, circular movements that create their own momentum, definitely have forces of input. Dr. Thornton is a force. His CV's list of invited lectures spans 3 pages, and it has to be limited to just the past 8 years for purposes of brevity. His list of peer-reviewed publications spans 7 pages. Dr. Thornton is one of the world's experts on congenital hyperinsulinism, and he's made Cook one of the world's most preeminent places to treat this disease. Dr. Thornton's endowed chair was one of the first ones awarded and has been tremendously successful. And as you know now, the virtuous circle doesn't just stop with Cook being preeminent in a rare endocrinologic disease. Dr. Thornton's expertise in this area, his success as an endowed chair, and his success in other research projects is part of the force that's made the entire Cook endocrinology department a force. I'll let Dr. Thornton fill you in on the details. Thank you, Dr. Thornton, for all you're doing, all you've done, and all you're going to do. Dr. Thornton, our keynote.
Thank you very much, Dr. Stegall. I think he forgot to mention that I use size 20 font. Okay, it's my pleasure to be here today. These are my disclosures, and most of them are related to the fact that we do a lot of industry-related research in Cook Children's, both in growth and in the treatment of hyperinsulinism. And then we may talk a little bit about some off-label uses that we're doing in the department. So today, what I wanted to do is to talk at first a little bit about why I came to Cook Children's and how someone like me, when I first started the idea of looking around and leaving my training institution, what the perception of Cook Children's was at that time. And I think after Dr. Stegall, you all know now that that perception has probably changed a lot. So in order to do that, I want to tell you a little bit about my own career and how a clinician ends up in Cook Children's. And then over the course of the meeting, what I'd like to do is to demonstrate the outcomes of the Endocrine Division Endowed Chair funding, so focus on my 2 colleagues and I on what we have done. Talk a little bit about specifically why I do research and the things that I enjoy about it. Talk a little bit about the benefits that research brings, particularly to the children with endocrine disorders. So starting off with my background, I was born and grew up in Dublin, Ireland. I went to medical school in Ireland, and that is a very different journey than we see with the students and the doctors here in the US. We have to choose to go into med school when we're in high school. We have to tailor our courses when we're about 16 to get to take the exams that enable you to get into med school. And then we go straight into med school. And then we do about 40 hours of lectures and work a week. None of this 15 credits a semester stuff. We do have time to go party, typically on Friday and Saturday nights, but the rest of the time it's basically studying and working hard. We do 4 years of preclinical and then we get into clinical work. And when I tell you the story of my clinical work, some of you may understand why I behave the way I behave. But the idea of clinical training in Ireland was that everything was about using your eyes, your ears, and your hands. There was nothing about using tests. I didn't even know how to order a test when I was in medical school. I didn't know what an ultrasound was because my job was to feel the liver and feel the kidney. Now, many of you would say, yeah, but that's pointless because how are you going to feel that little tumor in the kidney? Well, you're not really, but the point is that clinical exam is very, very important, and we are losing those skills as we go along, and I think it's very important that we maintain those skills, because there is going to be some time when you have a patient and they come in and they have a subtle liver and nobody knew they had a mild form of glycogen storage disease, and if you feel that liver, it sets you on the pathway to think about where we go. So it's very important, and when we were in medical school, we were truly beaten down by the consultants. We were at the end of the bed in front of 10 people, examine the child or the adult, and if you missed something, you got hauled out. So hence my slightly tougher approach while I'm teaching. It all comes, it's like we do what our parents do, right? Anyhow, I graduated med school. I did 2 years in general medicine and surgery, because in Ireland you're not allowed to go into pediatrics till you're somewhat skilled. Then I did my pediatrics, and interestingly for me, most of my pediatrics was actually neonatology. So I have done enough neonatology to become board certified. I just haven't done the exam, and I've forgotten most of it now. That was all done in Dublin and London. I came to Philadelphia and I did a sort of a combination of residency and fellowship in order to be able to get a license to practice medicine here. And while I was in my fellowship, I was funded primarily by both institutional and individual NRSA funding from the NIH. And I went on and won a Clinical Associate Physician Award, a CAP award, which allows you to carry on your clinical research into the early years of your career. However, I left CHOP and went home to Ireland to become a consultant and to be the only pediatric endocrinologist board certified in the country, although there were some physicians who were specialized in pediatric endocrinology, but I also had to do pediatric metabolism. And interestingly, because they needed me to do pediatric metabolism, the Irish healthcare system funded me to do a year's metabolic, fellowship while I was working as a pediatric endocrinologist in CHOP. So I had 2 jobs, and fortunately I was paid for both of them, but one was to be a fellow and one was to be an attending. And I got to travel up to Boston and meet with some of the world metabolic greats, people like Harvey Levy, who is a world expert in phenylketonuria treatment. So that was a fun year. And then I went back to Ireland and ran the National Centre for Inherited Metabolic Diseases. I came back to the States because they offered me an opportunity to open up a hyperinsulinism centre there and to run the clinical department. So all of this is to say that my career up till 2003, before I came to Cook Children's, was very clinical and very research oriented. And so when I looked at moving and the opportunity came to come to Cook Children's, everyone was astounded because they said, well, why would you go to a private practice hospital? And I said, well, it's a little bit more than that. But I think it was my love for clinical care that drove me to think that this would be a place for me, because even though there were no residents and there was no research going on that I was aware of, the idea of providing clinical care was something that, as an Irish medical graduate, was what we were trained to do. So I came here, and there was a lot of work to be done to build up the endocrine department. At the time, there were 2 doctors, 2 nurse practitioners. There was a wait time of 9 months to get in to see, and there was a wait time of about 9 months to get your letter after you were seen. So there was a lot of things to be done. We had to recruit a lot of patients, or a lot of doctors and nurse practitioners. But eventually in 2010, the inkling and love I have for hypoglycemia couldn't be held back anymore, so I went to the institution and said, I'd like to set up a hyperinsulinism center. And I said, I think we can do it here. There's only one in the country, and we need another one, particularly because places like Medicaid were not letting kids go out of state, and we were already sending all our commercial patients up to Philadelphia, but our Medicaid patients couldn't go. And I thought that was not fair, that they weren't getting the same care. And in 2012, I got my Endowed chair. Now, I want to talk to you about my publications, primarily because I want to highlight the effect that having an endowed chair made. So let me see, can I get this pointer? So this is my clinical career and training, and as you can see, most of that would have come from like 1991 onwards when I was a fellow and worked in CHOP. But I had a reasonably productive period of time that would have set me on the pathway to get promoted to an associate professor in UPenn and stay there. But I chose not to do that at the time. And so the next couple of years when I got to Cook Children's was sort of the effect of all the projects we'd been working on, wrapping them up, because those of you who do this know that it can sometimes take a couple of years to get things done. And then in 28 to 2012, that's really my true sort of independent Cook Children's time. And you can see that productivity really drops off, no peer-reviewed papers, a couple of book chapters, and a couple of abstracts at meetings. But really, I got into the mode of being a clinician and focusing on clinical work. And then in 2012, I got my endowed chair, which allowed me to have time and support from the research program to focus on getting back to publishing and doing research. And you can see over that time a clear, distinct difference between when I wasn't funded to do it. So the endowed chair, certainly in my circumstances, allowed me to have the time to do the things that we need to do. And the cool thing about it is that nobody said, okay, Paul, you got an endowed chair, you have to write 3 to 4 papers a year, you have to go to 5 meetings and give 10 talks. They said, take this endowed chair and do good work. And because I was doing it for fun, it was so much better than when I was doing it in the University of Pennsylvania. And that was a huge difference. So not only do I have an endowed chair in endocrinology, but as Dr. Stegall said, so also does Dr. Wilson and Dr. Roy. And you can see even in Dr. Wilson, who came to us as a world expert, that the amount of publications on his CV before getting the chair versus after getting the chair is dramatically increased. And I think I can say for Dr. Wilson that the endowed chair has also given him the time to focus on research and publications. And I think he would agree with me that he's doing it for fun, and it is great fun. We certainly enjoy it. And recently, Dr. Sani Roy, one of our younger doctors, got an endowed chair, and she is focusing her research in a condition called Prader-Willi syndrome, and she's already started off publishing and working on multiple papers. So what I wanted to say here was that, people come to Cook Children's for many, many reasons. And in the past, I think they came because they loved clinical medicine. They didn't like the bureaucracy of academia, and maybe they didn't enjoy research and publications. But now with the Endowed Chair program and the wonderful research organization we have, now we can attract people to come here who want to do research, who enjoy clinical medicine, and who just don't like the stuff that goes on in academic centers. So I think this Endowed Chair program has clearly opened Cook Children's to recruit a more varied population of physicians and non-physicians who want to come and work here. So what has the effect been? Well, firstly, the Endowed Chair has allowed those of us who were very interested in our work is to go on and develop or continue our recognition as world's leading experts in our fields. And you can see that based on the publications. But if you look at the list of the publications that we've had, both Don and I have been lead authors for international guidelines. And so it's not just that we're publishing, it's that we are at the cutting edge and leading the way for the treatment of diseases such as hyperinsulinism and lipid disorders that Dr. Wilson does. We get invited to go and lecture all over the country and world. And last year I had 400,000 miles on American Airlines. Yeah. I got to Iceland, the Faroe Islands. I got to see Europe. And that's fun. And you go on these trips and you do your work and then you stay a few days and you get to see the world. So the Endowed Chair program will broaden your horizons and take you to places in the world without having to join the Navy. Both Dr. Wilson and I have had visiting professorships, which is really exciting because we get to go to other institutions and spend 1 to 2 days, and we teach the medical students and we teach the fellows. In my case, we teach the neonatologists and we talk to the endocrinologists, and it's really a fun thing. And at the end of the day, I have to say that when I come home from one of those trips, I'm invigorated to come back, and meeting all of the younger trainees has been very exciting, which leads me to some of the things that we're doing now with the development of research here. We're having the opportunity to work with medical students, which is really a fun thing to do again. But not only has the Endowed Chair done that, but it's brought clinical research opportunities for our patients. So for me, obviously, the Endowed Chair allowed us to set up the 18F-DOPA program, which I'll talk to you a little bit later. But this is a drug that's under investigational new drug license from the FDA, and it's not FDA approved, so everyone who gets 18F-DOPA has to be in the study. And so that's brought cutting-edge medical care to patients with hyperinsulinism to the south of the US. And we get patients come to us from all over the southern states and central North America. So that's been exciting. We've even had patients come down to us from Canada. By having an endowed chair and being involved in research, suddenly it became much more feasible for our department to participate in pharmaceutical company-sponsored research, because even though they take care of lots of the stuff, you still have to go through the IRB and do all of that. And so having time with the endowed chair has allowed me to be the principal investigator, even if, for example, one of my other docs wanted to do the study, but they just don't have time to do all of the paperwork. So that's been a great advantage. And it's also allowed us to help show them how to do this. And I have to say the amount of support we get from the research organization is huge, and we couldn't do this without our team. But we've done studies for patients with growth hormone deficiency, patients with idiopathic short stature, with daily growth hormone. We've played a pivotal role in the long-acting growth hormone studies. So this is growth hormone that's given once a week instead of 7 times a week. We've helped develop novel hyperinsulinism treatments, particularly 2 drugs, Xeris glucagon, which is a liquid formulation, got approved not for hyperinsulinism but for rescue and diabetes, but we did some of the pivotal studies in the hyperinsulinism patients, and we did some studies with dasiglucagon, which is a treatment we use to treat the diazoxide unresponsive hyperinsulinism kids. And so these are treatments that are currently underway with the FDA for approval that our kids here have had for years, and it's helped them to change their medical care. And now Dr. Roy is looking at some novel Prader-Willi treatments. But there are other benefits that we've had. Both Don and I have had the opportunity to serve on our professional societies. I've been on the board of the Pediatric Endocrine Society for 3 years, and now I'm just back for a stint as treasurer, so I'll be able to siphon off some of the funds and get even more vacations. Dr. Wilson has won some National Society awards, and there's a big one he's about to get that nobody knows about except him and me in May of this year, so that's very exciting. But I've had time to have service on family support organizations. So I'm on the scientific board for Congenital Hyperinsulinism International, and that's an organization that helps children with hyperinsulin all over the world. I'm on the scientific advisory board of the Ketotic Hypoglycemia International family organization, and that one in particular has brought children to us from all over the country because there are very few people who specialize in the idiopathic forms of severe ketotic hypoglycemia. So that's been great. Having the time to do our Endowed chair has allowed us to build our hyperinsulinism program and become recognized as one of 5 centers of excellence in the world. And then we get to work with those other centers of excellence. So it not only do we teach them, they teach us, and it's been a wonderful experience. As I mentioned, both Don and I have written guidelines for treatment. And we've had collaborative grants with the NIH, not an oral one, so congratulations. But we had a small business development grant from the NIH to help develop liquid glucagon. And I was part of a Chan Zuckerberg initiative where we got a $450,000 grant to set up a research collaboration. So the money may not have come to Cook Children's, but these are things that we've been able to do. And the Chan Zuckerberg initiative has really allowed us to build a research collaboration all over the world. And that's going to dramatically increase the awareness and publications that come out of all that work. Right now, our big thing is we're trying to influence how newborn screening is performed to detect babies with hypoglycemia. So why do I do research when I could, go home at 5 o'clock and sit on the porch, have a gin and tonic and watch the sunset? Well, it's because research is really exciting. Firstly, someone comes to you and says, hey, we've got this new compound that we think will make a difference in the lives of children, and you get to learn all about the science. I mean, we learned all about, when we were in Copenhagen this year, how they developed dasiglucagon. We met the scientist who had the first idea that if I altered these amino acids, I can make glucagon. If I switch out amino acids in the protein, I can make glucagon soluble. And for those of you who know someone with diabetes, to give an emergency shot of glucagon, you have to take the powder and the liquid, mix it together, and then give the injection. And when you're in a time of panic, about 25 to 30% of people just inject the liquid and forget the powder. So to make a soluble form of glucagon, and there are now 2 versions of that, was very exciting. But I would never have learned about all that protein chemistry and structure if it weren't for this. It's very rewarding when you offer a child and their family the opportunity to get a therapy that they might otherwise have to wait for. So for example, back 10 years ago, we did studies on idiopathic short stature. So this is a condition in which children are shorter than they should be. They're not growing properly, but we can't find a reason, and they're not growth hormone deficient. And so we were able to enroll 15 to 20 kids into this study, give them growth hormone, and they grew to an improved final height. And that was really beneficial. So you can imagine how excited the parents and the kids were. So when you have one of those research visits, it's typically nothing but joy. The people are really appreciative. So for me, it's very rewarding, and this prevents burnout because, if I have a rough day in clinic, I know that tomorrow I'm going to see one of my happy research patients who's grateful that we got them dasiglucagon and they didn't have to have their pancreas removed. So that's a big deal for me. We've talked about getting therapies that they would have had to wait for years for. But another advantage is I get to connect with world experts. So, for example, we're doing some CAH, congenital adrenal hyperplasia, studies developing some new drugs for the treatment of this, and I get to hang out with the likes of these experts from Europe and adult endocrinologists who are world experts, and that's very exciting. And listening to them talk helps me come back to my clinic and say, wow, we can do a better job here of treating the patients who are not in the study. And so that's been a real benefit. And working with the research team is fun. I mean, they're a great bunch of people, and we really enjoy what we do. And yes, there are days where it's stressful and we got a lot to cram in, but overall, I would say we have a lot of fun. So the sort of benefits that the endocrine department has had is, we got daily growth hormone for children with idiopathic short stature. That led to several publications in hormone research in pediatrics, and it led to FDA approval for the drug. So now about 1/3 of all the patients we have on growth hormone have idiopathic short stature. And so that's really exciting to be a part of that. And, you know, the kids, we tell the kids when they finish the study, we thank them and we say, you know, what you did has helped bring this drug to the market for other kids coming after you. And they're really proud. You know, sometimes we'll make them up a little badge that says, you know, I participated in a research study. You know, I think we could do more of that sort of stuff. Maybe we should get an official T-shirt. Swag from the research department, yeah. We were involved in the weekly long-acting growth hormone studies with 3 different pharmaceutical companies, and we got 3 publications out of this, and this enabled now 3 of those drugs to be FDA approved, and so now children can get 1 growth hormone shot a week instead of 7. And then we played a pivotal role in the 3 studies that have got dasiglucagon into the FDA, and it would have been approved, only they had a tiny manufacturing glitch in their manufacturing plant, so the FDA put it on hold. So we expect that to be available. So that leads me into talking a little bit more about hyperinsulinism and the work that we're doing here. This is a condition in which insulin secretion is uncoupled from the plasma glucose levels, resulting in inappropriate insulin secretion. So normally what happens is your blood sugar goes up, you make insulin, it brings your blood sugar down, you stop making insulin, and so you stay in a very narrow range of 70 to 120 milligrams per deciliter. But in these children, they've got dysregulation, and in some of the conditions, particularly the ATP-sensitive potassium channel defects or the KATP channel defects, these kids are basically blind to glucose. So the blood sugar changes up and down, the beta cell no longer recognizes that the glucose has changed, and it just keeps secreting insulin. And so what you see is primarily a hypoglycemic disorder, but you also see post-meal hyperglycemia because the beta cell is blind to rising blood sugars as well as falling blood sugars. So they're not able to increase the amount of insulin, they just secrete insulin independent. Hence, it is a very erratic disease with hypoglycemia at unexplained times, and then you're scratching your head with puzzlement because why is the blood sugar over 200 now? There are 2 major forms of hyperinsulinism, acquired and the genetic forms. The acquired forms are primarily perinatal stress hyperinsulinism, and this, in fact, is probably the most common form of hyperinsulinism. It occurs about 1 in 1,200 to 1 in 1,800 newborn babies. The vast majority of those children have severe hypoglycemia requiring very high glucose infusion rates, but over time it settles down, and in about 1 in 5 babies, it persists beyond 7 to 10 days, and those babies need to be treated with diazoxide. And our team did a very nice study looking at patients in our Tarrant County area, and we were able to, for the first time, define the exact rate of babies who need to be treated with diazoxide as approximately 1 in 6,000 babies. So that's exciting new work that we had done. And then there's the genetic forms of hyperinsulinism that can be classified as monogenetic, and by that, obviously it's a single gene, but we really mean monosymptomatic, meaning the only problem the patient has is abnormal insulin secretion, or it can be part of a syndrome where the patient has a syndrome, be it Turner syndrome, Kabuki syndrome, Beckwith-Wiedemann syndrome, so they have multiple features of multi-system disease, and one of them is hyperinsulinism. And so we're going to focus the rest of the talk primarily on the monogenetic forms of hyperinsulinism where hypoglycemia is the only real problem they have. So the clinical features of hyperinsulinism are that they have profound and persistent hypoglycemia. Typically, most babies will present in the first days of life. The babies who present later, we showed at Cook Children's that 75% of the babies who present outside of the first week of life were missed in the newborn period. And this is why I have a passion to improve newborn screening. And when you go back and you look at their histories, you'll see there were so many clues. That baby had bad hypoglycemia that was very low. The baby needed IV dextrose. And then what happens is that the babies are weaned off the IV dextrose. They're having hypoglycemia on 3-hourly feeds. So we move them down to 2 hourly feeds, and then we get a couple of blood sugars that the AAP says are okay, and we send them home. So here in Fort Worth, we have had a huge impact working with our neonatologists in developing a 6 to 9 hour fasting study so that anyone who needed IV glucose has a fasting study before they go home, instead of just saying we got 2 normal blood sugars, out you go. And as a result, we've been able to identify all these kids and not send them home. And we have basically all of the local neonatal units in our catchment area doing this. So this has been very exciting. Now, these babies typically require high glucose infusions. They have low beta hydroxybutyrate and lactate because of the biochemistry of the disorder. And that's very important because, as many of you know, there are 3 fuels for the brain to generate energy: glucose, lactate, and beta hydroxybutyrate. And in hyperinsulinism, the glucose is forced low, the ketone production is suppressed, and there's no reason for them to build up their lactate levels, so they have no fuel for the brain and are very high risk of brain damage. And indeed, 20 to 40% have brain damage. There's only one FDA-approved therapy, diazoxide. It acts on the KATP channel, so you can imagine that if you have a defect in a gene encoding the KATP channel, then diazoxide is not going to work, and that's what we call diazoxide unresponsive. And 95% of patients with diazoxide unresponsive HI have the ATP-sensitive potassium channel, the KATP channel defects. We've learned over time that there are 2 different types of histopathological changes in the pancreas of babies with hyperinsulinism. And we noticed this back in the 60s, but it wasn't really fully clarified into the 1990s, where people recognize that there are patients who have diffusely affected islets throughout the whole pancreas, and there are other patients who only have a small focal area where that pancreas is abnormal. And in the late 1990s, our team in Philadelphia, and when I moved back to Ireland, working with some of the scientists over there, Fergus Ryan, we were able to determine that focal hyperinsulinism is caused by a 2-hit process. One is you inherit a recessive mutation from dad, and the second hit you have to get is you lose a part of the maternal chromosome 11. So here's a cartoon to describe it. And what you can see here is chromosome 11 and the 2 genes KCNJ11 and ABCC8, which are located on the short arm. And in diffuse disease, you have a mutation in both the maternal and the paternal copy because it's autosomal recessive, or you could have a dominant mutation in one, and as a result, the whole pancreas secretes insulin abnormally, and if you take some of the pancreas out, whatever you leave behind still secretes insulin abnormally, so you can never cure the child. All you can do is give them diabetes or lower the amount of insulin-producing cells so that maybe you can control it a little bit better. On the other hand, when you have a paternal carrier and the father's gene is in blue, I'll call it here, and you can see that's got a mutation and the mother's chromosome 11 is completely normal, then you have a heterozygous state, you're a carrier for a disease. So this part of the pancreas is basically a carrier, and just like the parents is completely normal. But over here in this focal lesion, there's a loss of a part of maternal chromosome 11. So now you only have one copy of a gene that causes hyperinsulinism, and you've no, it's a recessive copy, but you've no balanced recessive normal or normal copy in the maternal allele, so you get a focal lesion. But it's not that simple, because it turns out that these focal lesions, when we remove them under the microscope, show that there's massive proliferation. And so we need to go back to our imprinting understanding. And here's the maternal allele, here's the paternal allele, here's the mutation in ABCC8, and this little symbol here indicates expression of imprinted genes. So normally on the maternal allele, P57 is expressed, and that's a growth inhibiting gene, and H19 is expressed, and that's also a growth inhibiting gene. And the idea is that if you're a mom, would you rather deliver a 5-kilo baby or a 3-kilo baby? Hands up for 5? That's what I thought. Yeah, so the idea is that the mom suppresses the growth of the fetus so she can survive the pregnancy and live on to deliver another baby. Whereas on the male, IGF-2 is expressed, which is a growth-promoting gene. The idea being that who here is a dad would like to have a big strapping son. So nature is designed to help the fetus survive. The mother wants the fetus to survive and her to survive, and then we want the babies to be big and strong. So if you can imagine then that if you lose these growth inhibiting genes and you only express the growth promoting gene, that you get this focal area of excess growth. And that's why these focal lesions, as tiny as they are, they can be 2 to 3 millimeters in size, can secrete massive amounts of insulin. So how do you clinically differentiate diffuse from focal? The answer is you can't really. There are some things, like for example, diffuse disease tends to be more severe and present a little earlier than focal disease, but there's enough overlap that you can't tell the difference. Diffuse babies tend to be heavier because of the in utero excessive growth from insulin, but focal babies can also be a little larger, and so there's overlap. You can do a critical sample and look at all of the labs, but there's overlap and you can't tell the difference. So there is no clinical way, and as an Irish physician, of course, that upsets me greatly, that I can't tell the difference between focal and diffuse with my hands. So people tried imaging, ultrasound, CT, MRI, and because these are more functional abnormalities rather than structural abnormalities, you can't see any difference there. And so back in the early 2000s, people had tried PET imaging with labeled glucose, thinking that if the cell is making more insulin, maybe it'll be using more glucose, and we could see it, but it turned out not to be the case. But it turns out that 18F-DOPA is an agent that we can use, and dopamine gets co-secreted with insulin in the beta cell, and 18F-DOPA is a precursor, so it gets incorporated into the manufacture of dopamine, and you can tell which cells are making more insulin than others. And so we applied for an investigational new drug license. I think we were the first people in Cook Children's to get an investigational new drug license at that time, although I'm sure neurology will tell us we're wrong. There's no competition, by the way, no competition whatsoever. Our program, we got this IND approved in 2014. And since we've done that, we've now imaged over 90 patients, of whom 69 had surgery. And if you want to learn more about our 18F-DOPA program, please stop by Deborah Rafferty's poster. But approximately 67% of the patients are focal, 18% diffuse. But we've now learned that this scan picks up children who have mosaic Beckwith-Wiedemann syndrome. So on the outside, the baby looks normal, but they're mosaic for Beckwith-Wiedemann syndrome, so they have internal organ proliferation, and they have an abnormal pancreas that oversecretes insulin. And in the last few years, we started to look at patients with insulinomas. So our PET scan program, even though we're not the first in the world to do it, has contributed some important things. The first thing is that when we started out our PET scan program, no one actually knew how much radiation the patients were getting exposed to. So with our colleagues in BRF in Louisiana, who manufacture our 18F-DOPA, we were able to do dosimetry studies and look at the dose of radiation that each organ gets, and that was published in PLOS-1. There was also a lot of debate about how you interpret the PET scan, and most people were using what we call the specific uptake value. And the specific uptake value is where you put a cursor over the region of interest and you count the amount of counts coming out of that area, and then you put another cursor over a region that is not of interest, and you compare the counts. And if the ratio was greater than 1.5 or 1.3 between the area of interest and the rest of the pancreas, that would indicate a focal lesion, and you would then go operate and cure the patient. Whereas if it was less than 1.3, then that would indicate diffuse disease. And in many parts of the world, that would mean that we do not operate on the patient and we just treat them medically. What was different about us and Cook Children's is that our patients were wanting to be operated on because when they saw what was required to manage the patients medically, they would say, well, boy, we can't do that. You know, first you're going to be in the hospital for a long time, then you're going to have a G button placed, you're going to become G-tube dependent, the child wasn't going to eat for 3 to 4 years, they're going to have to measure the blood sugar 10 times a day. If the G button got disconnected, they're going to have profound hypoglycemia because none of the medicines were working. So they would choose to go to surgery, and because we went to surgery, we had a protocol in place where we took 3 biopsies of the pancreas, and if those biopsies were normal, it indicated there must be a focal lesion somewhere else. And if those biopsies were abnormal, it indicated that the patient had diffuse disease. So we were able to demonstrate basically that using a visual interpretation is better, and that if you go on SUVs, you're going to miss a lot of focal patients. And in Europe, they PET them, and if it's not classically focal, they don't operate, so they're missing a load of patients that they could potentially cure. So we've operated on more, but this is our latest outcome. We've cured 37 out of our focal kids. 3 had hypoglycemia. 1 we couldn't cure because they had portal hypertension as a result of a UVC in the hepatic vein that blocked the portal, in the portal vein that blocked the blood supply. And when we went to open the patient up to operate on the pancreas, it was just a massive venous dilatation, and we probably would have exsanguinated the kids, so we closed them up and didn't operate. And then a couple, we just have not been able to get the full focal lesion out. Whereas with diffuse disease, you know, 11 of them had hypoglycemia and 1 had diabetes afterwards. So you can see there's very little utility in operating in the patients with diffuse disease. There are many things that, you know, can go wrong with patients with hyperinsulinism, and one of them is how they end up being fed. And our program here in Cook Children has the best feeding outcomes of any program in the world for hyperinsulinism, because when I walk on the unit and see an NG tube in the baby's nose, I just pull it out and say, feed them. So when the nurses see me coming onto the NICU, they all go, uh-oh. But what you can see here is that the focal kids really do well. This color is the focal kids on discharge, and most of them, because we cure their hypoglycemia, even if they were tube dependent, 50% of them are tube dependent when they come to us. We just basically starve them into eating, and in 3 to 4 days of very poor oral intake, they get hungry, they start eating, and they go home fully fed. We've had a couple who didn't go home fully fed, but they very quickly, at longer term follow-up, are fully fed. So focal disease, you can not only cure their hypoglycemia and eliminate the risk of that in the future, but you can also ensure that they have a normal daily life with normal feeding. And you can see the diffuse kids at time of discharge and even later on, because feeding is part of their therapy, have a much more higher rate of requiring either continuous nighttime feeds through the G button or a supplementary PO and tube top-up because they just won't drink enough, and some of them even become tube dependent. But as I said, these numbers are far better than others. In many other institutions, the babies with focal disease, 50% of them go home on tubes, but eventually over time they learn to eat. So that's been very good. So I wanted to talk quickly about our experience with diazoxide unresponsive diffuse disease. We've had 25 patients over 9 years. And what we did is we looked at you know, how they get to us. 19 came to us from the birthing hospital, and the vast majority, 80% of those kids, needed surgery before they left here, and 6 of them were referred to us greater than 4 months old. Many of them had gone home and they were on medical therapy, and some of them had sat in the NICU for 4 to 5 months and come to us because they just couldn't get home. And then we also, and so 2 of those required surgery immediately, and 4 of them were able to go home. But what we found is that of the medically managed patients that we sent home, half of them came back to us begging for surgery because life with hyperinsulinism and diazoxide unresponsive disease is so severe. And this is why it's very important for us to develop novel drugs. Overall, our rate of surgery in diffuse disease is 84%. So at the European Society of Pediatric Endocrinology last year, we presented a poster looking at our outcomes versus the other centers of excellence. And you can see here that there are 4 other centers of excellence for the treatment of hyperinsulinism. The Danish group is not a center of excellence, but they have a large number of patients. And you can see here that in this center, 80% are medically managed. In this center, 60% are medically managed. In this center, this is France, 100% are medically managed. They just won't operate. And in this center, 90% are medically managed. So you can see we are very different than everywhere else. And one of these is an American center where we are also higher in terms of surgery than they are. And you can see in the Danish, it's about 60-40. So we wanted to see, boy, were we just doing something different? Well, again, this is a nice study that Deborah Rafferty is going to present at a poster later today. But we looked at the pre-treatment max glucose infusion requirement to keep their blood sugar above 70. And in the ones that we did immediate surgery, this was at 17.4. For those of you who don't know, normal is 4 to 6. So these were 3 to 4 times higher glucose than normal. So you can imagine if you had to feed them that amount of glucose at home, those babies are going to be overfed, obese, they're not going to be hungry, they stop eating, and they become tube dependent. And then if something goes wrong in the treatment, they have profound hypoglycemia, putting them at risk of brain damage. The group in whom we tried to treat medically had a much lower glucose infusion rate. We sort of think that if you can get your glucose infusion rate below 10, that you can be treated medically. And so here they are on diazoxide, and the ones that we did surgery on immediately had absolutely no response in terms of reduction of glucose infusion rate, whereas group 2 had a partial response. They lowered their glucose infusion rate, but they did not come off glucose at all completely, so we had to do something with their feeding. So this is the treatment algorithm that we've developed. A patient is diagnosed with hyperinsulinism. You try diazoxide. If it works and you're able to keep their blood sugar greater than 60 for 9 hours, you can send them home. And that's a small proportion of the kids we see. It's almost all of the acquired hyperinsulinism and none of the genetic. And then if they're unresponsive, you do genetics to tell you if there's a chance it's focal. You do the 18F-DOPA. And then if you do a pancreatectomy, you can cure those focal kids without giving them diabetes. And these are our outcome numbers. We've now seen over 382 kids with congenital hyperinsulinism. And remember, this is a very rare disease, 1 in 30,000 about. We've done 99 pancreatectomies as of December, but last week we did our 100th. And that was very exciting because we cured that baby. We have one of the shortest length of stays in any of the hyperinsulinism centers in the country, with 23 days for the focal, 27 for the diffuse, and our insulinoma kids are even shorter in and out of the hospital. We have one of the best outcomes in terms of sepsis. We've only had one patient who developed a line infection over the course of the years, and of course that's primarily due to our great nurses in the NICU and on 3 North. And so the program has been very successful and helped a lot of children. So I'm going to wrap up and say that overall, I think the Endowed Chair program has had a very positive effect both for me in the endocrine department, and I would like to take the opportunity to thank the institution for developing the program, and I would strongly encourage them to continue to expand the program. I think the return of investment is huge in terms of the things we're able to do for our patients, how we can improve patient care, the novel therapies we can bring, the notoriety we can bring to Cook Children's. Our research in endocrinology is primarily clinical, and we've helped bring many drugs to the market, so that's been very satisfying. Our clinic is now a world-renowned center, and most importantly, research is a team sport. And thank you to my team. I could not do it without you. And here are some of my team. And thank you to our wonderful photographer, Haswell Inc. And I'll stop there and say thank you all for listening. think we may have 2.5 minutes for questions if anyone would like. It was just that Dr. Stegall's introduction was so long.
I won't ask all my questions, although I do have, it's not quite your length of CV, but it's long. Okay. I use the FDOPA program as evidence that you can't actually provide good quality clinical care for this disease without research, right?
Right.
So there's no indication the FDA is ever going to get around to approving FDOPA. It effectively, I think, is standard of care if you have congenital hyperinsulinism.
Right.
Can you speak to this? The way we're taught is that there's standard of care, and then there's quality, and quality is about making the best standard of care everywhere, right? And then there's this research thing, which may or may not work. We're supposed to keep arm's length from it. We're supposed to have equipoise, but then FDOPA does not look like that. So speak to that, and then broaden that. Is that? I think that's where the world's going.
Yeah.
You can't do it.
I mean, I think the issue is that sometimes it costs, anywhere from $250 to $1 billion to develop a drug for market. And in the United States, there are 50 PET scans a year. So the cost to get that through to market is huge, and then the cost per patient would be massive. It actually only costs $5,000 to make a dose of 18F-DOPA, but to pay for the research and the application, even though this is a rare disease, it would still be very expensive. So it's prohibitive, and nobody wants to do it. Now, interestingly enough, the Society for Nuclear Medicine may have negotiated with the FDA a pathway to get this approved. So we'll see if it does get approved. And they are going to then allow everyone to use their FDA approval by just submitting a, what's it called when you do an additional, not an NDA, an ancillary new drug application. However, having said that, this is the standard of care, and unless you have access to 18F-DOPA, you cannot determine the patients with focal disease where the lesion is and cure them. So this is a real dilemma that there are only certain places in the country who can do this, and that not every child has access to it. And in Cook Children's, we've been really good at taking everyone who's referred to us. I mean, we've had patients, quite frankly, that the bill was $600,000 and they paid us $13,000. But it's one of the things that we do here is we focus on the patient and providing the best care and not on the finances. And luckily for us, our institution is so good at managing the finances generally that we can afford to take these hits here and there for these special rare cases. So yeah, I hope that answered your question. Endowed Chair Roy.
Paul, you briefly mentioned this, but I would really like to know your thoughts on where we're at with getting hyperinsulinism on the newborn screen. Is that something that you think will happen, and where are we in the process?
Right now, the answer is no, because yes, we could measure glucose on the newborn screen, but the problem is that the overlap between normal and abnormal is so great. It depends on the timing. If you do the newborn screening in the first 24 hours, 50% of patients will have a blood sugar less than 45. So how do you interpret that? There's a group of us are looking now at using a combination of glucose and beta-hydroxybutyrate to determine if after 48 hours of life, if the glucose is still low, if you measure the beta-hydroxybutyrate, that indicates the baby is starved if it's high, and so all that baby needs with their low blood sugar and high ketones is to feed them, whereas if they have a low blood sugar and low ketones, then they have a pathological condition, of which there are many other than hyperinsulinism, and that would be a way of doing it. So then the question is could you do that on a newborn screening? But the problem with that is in the 5 days it takes to get the result back, you could have damaged that kid's brain. So what we really need is improved awareness amongst the community of doctors who take care of newborn babies, that blood sugars that are persistently below 50 in the first 24 to 48 hours are persistently below 60 after that, or babies who need IV dextrose, they do not have the normal transitional changes that babies go through, and they need to be investigated. So that's the focus right now. is trying to get that message out, and we're looking at this combination of glucose and ketone, and if you measure your glucose in millimoles and your ketones in millimoles, if a baby has a combined glucose and ketone of over 4 after 48 hours, they most likely don't have hyperinsulinism. So it's a help, but it's not enough.
What's the future of hyperinsulinism? Is this a surgical disease that is always going to have to be managed that way, or do you have gene therapies on the
Yeah, the future is new therapies. So we've done some studies with an antibody that binds the insulin receptor and blocks insulin action at the receptor, and therefore, even though these babies would make excess insulin, the action of insulin is blocked, and that's a drug called RZ358. And we were involved in the phase 2 studies, and the phase 3 studies are just starting in Europe. The FDA has blocked it in the United States because there were some rats in the preclinical studies who got liver problems, and it has not been seen in mice in preclinical studies, and has not been seen in chimpanzees, and has not been seen in humans in the clinical studies, but the FDA has decided to stop the study. But this is a shame because it's a really good drug, and in Europe, the regulatory agencies realize that this disease causes brain damage in up to 40% of people, and this tiny, tiny risk of liver dysfunction is worth the study. And yes, we tell the patients that, and the patients all enroll in the study. So I think new medicines are the way forward. Dasiglucagon is about to be approved, and that's given as a continuous infusion. And there are some GLP-1 reverse agonists that are in development that will block insulin secretion, and they'll also work. And there's an oral somatostatin drug, and all of these we've been involved in the development of, that will block insulin secretion. So the future is going to be medical therapy for all diffuse kids that's effective, and focal surgery and cure for the focal kids. Great. Well, if there's no other questions, let's get back to Eaton.